So we're going to go through a few different pages that I got as a doctor on my weekend cover shift, and also a couple of pages I got over the course of my night shift. Let's go through how I went through them, how I tackled them, what the page actually was, and maybe how you can go through it as well. So yeah, if you don't know, a pager is what we carry around. It's like a little Tamagotchi device, and essentially it's how we communicate throughout the hospital. If people want stuff done, they go on the system, like the computer app, they type a message and they say, please do this, or can you come see my patient? I'm worried about them. If they're really worried, they'll call over the loudspeaker through the PA system, but if it's a sort of non-urgent, or they want you to call them back, you have to send a message on a pager. All right, so the first page, UR 12345, please cannulate patient, NBM requires IVT, too difficult, IVC. This is probably one of the most common pages that you get as a doctor. It's essentially asking you to pop in a drip for a patient who is NBM, which means nil by mouth, and that might be for a variety of different reasons. I actually can't remember why this patient was nil by mouth. I think they were fasting for an operation, and that's a really common reason why patients are not allowed to have any oral intake, because we like to have people fasted for surgery, and usually the rule is like 2 hours before the surgery you can't drink anything, 6 hours before the surgery you can't eat anything. Now, we can't predict the future, believe it or not, so we actually fast people for a long time and give them fluid through the drip instead of actually giving them food and water and coffee and tea and orange juice and all the other random stuff that you can eat and drink. But yeah, so we keep them nil by mouth, we supplement them so that they can keep living as like a normal human with intravenous therapy. So that has all like the electrolytes and fluid that the body needs to function. And yeah, they look like they've had a couple of goes at putting in a cannula. It says a difficult IVC, which is an intravenous cannulation. Now, that could be for a variety of different reasons. Yeah, maybe the person trying to put in the drip wasn't as experienced, or maybe they were very difficult to cannulate the patient. You know, maybe the patient wasn't the easiest person. They had like, you know, small friable veins, or yeah, maybe like the person had quite a high BMI and you can't actually visualize or feel the veins as easily. So yeah, they might need to employ something like an ultrasound guided technique to find the vein that they want so that they can pop a drip in. So essentially this is like a non-urgent page. You need to pop in a cannula when you can. It's not something I'd be like leaping out of my seat to do right away, unless I was about to finish the shift and I needed to do this before I could hand over. Yeah, that's how I did that one. All right, next page, number 2. So patient Jones, UR 12345, needs reg meds charted. This is a different patient than the first patient, but essentially this is one that most commonly occurs after a patient has recently been admitted. Maybe they've come in through the emergency department, now they've come up to the ward, they need their regular medications charted. The other reason is that maybe the patient has had an operation, they're staying overnight, or they're staying for a couple of days. They need their regular medications charted because they're going to be admitted as an inpatient. That's a pretty straightforward one. It really depends. Regular medications being charted can take all of 1 minute if they don't have any regular meds, or it can take 10 minutes just clarifying all the specific doses, especially if they're like complicated patients with interesting medical conditions. You know, there might be titrated doses, or they might be on some like different steroid regime or anticoagulation regime. Maybe they have, you know, doses on particular days of the week and they differ or something like that. You know, they might have like, yeah, complicated medications, especially in the perioperative period. Medications that we worry about are like blood thinners and insulin and things like that, and they need to be changed or altered depending on how the patient is, either preoperative or postoperative. It's actually a bit of a stitch up if you have to do it on paper, because that's when you have to like write down the doses of everything. It doesn't pop up on the screen, like it doesn't prompt you with like pre-filled data. So I'm currently working at a hospital that has an electronic system. I'm moving to a hospital that doesn't do that. It has a paper system for charting all these things. So that's going to be a big adjustment when I go there. But yeah, can be frustrating and very time consuming. All right, next page. Let's go through it. So please review. Patient due for 3 antihypertensive medications, systolic blood pressure 128 now. Yeah, so I mean, this patient is essentially got a normal blood pressure. A systolic blood pressure of 128 is like bang in the normal range. It is not low and it's not high. They are usually taking 3 antihypertensive medications. Now, you wouldn't really give it in this situation because the patient is not hypertensive. If you're going to give them 3 antihypertensive medications, you might actually cause their blood pressure to drop. And then you're dealing with a hypotensive patient. So people come into hospital for a reason. They are not their normal, like, healthy selves, and maybe they haven't had enough to drink or eat, or maybe they've got some losses from somewhere. Maybe they've got a gastrointestinal illness. Maybe they've just had like some bleeding from some part of their body, or maybe they had an operation or something like that. Their input and output of their body fluids is not normal. Or maybe they're like sick with like some other illness that results in like third spacing of fluid or something like that. And it might not even be like an intravascular problem. Like there might be some other thing where there might be an infection and it's causing like systemic vasodilation from like a sepsis response or SIRS response or something like that. So essentially, like, just because a patient is on normal medications in the community does not mean that they should always have them in hospital. And you know, if people usually have high blood pressure and now their blood pressure is 128, you need to think about what the cause of that is. Has that been a normal trend for them through hospital? Or are they actually sicker than what they were before? Because if the patient's blood pressure has been sitting at like 160 and now it's 128, like that's a big drop. So why is that? Is that a predictor of something that's going on for them? Because a drop of 30 of blood pressure is, you know, might indicate that they're actually getting sicker and they might actually continue to drop their blood pressure. So yeah, first and foremost, I would just like not chart these medications, just withhold them, and you can just withhold the dose. Or if it's been, if the blood pressure has been like low or normal throughout the admission, you can just withhold the medication completely and just review it if their blood pressure increases, because then you have normal medications that you can give that patient. And then if their blood pressure keeps going lower, obviously you're not going to give the antihypertensive. So yeah, and it might be worthwhile just to check up on how the patient's going overall, their other obs, you know, what they look like. You might go and see the patient, just assess them at the end of the bed if there's been any massive changes, because if something's dropped all of a sudden, then you should investigate that for an appropriate cause. So yeah, that's how you deal with that one. Yeah. So yeah, let's move on to the next page. Now, it just says ED bed 6. This is a genuine page that I got and I had no idea what to do with it, because it can be very frustrating, especially when you get a page like this, because there was actually just a bed number in ED. There was no callback number, there was no patient name, there was no person who was on the, like, there was no person mentioned that was the sender of that message. So I had no one to ask for if I just generally called ED. I had to do essentially all the digging. If there is any tutorial on how to do a page or how to send a proper page, this is the complete opposite of that. I actually did some digging. It was a patient who actually was admitted under one of the surgical departments on my cover shift. I think it might have been a vascular surgery or plastic surgery, I can't remember. They needed a heart rate modification. I had to go down and see them, look at the ECG. It was all normal. Well, it was relatively normal, just a bit slower than usual. They needed heart rate modifications before they came up to the ward, but because that's what is the criteria for our hospital. So sure, a patient might have a lower heart rate. It might be benign or insignificant for the moment, and it's not something that we can, you know, we're just going to watch and conservatively manage for now. So people, before they come up to the ward, need to have these modifications in place so that they, if people just come up to the ward and they have like really abnormal OBS, then they're just going to either call a UCR, which is an urgent clinical review, or a Met call, or even a code blue if they're very, very worried about that patient. So essentially you just want the people coming up or moving around the hospital to be stable. Yeah, the last thing you want to happen is for something to go wrong for a patient in the transit of that particular patient around the hospital, or in a new ward where no one's really familiar with them, and not the proper communication has been done to hand over that patient to the other people who are going to be looking after them. So yeah, this was a little bit frustrating. It put the onus completely on me. I could have just completely ignored it and said ED bed 6, like that's not my problem, but because you've received some information, you have an onus, you have a responsibility to sort that out, albeit it is like terrible communication. So please don't do this. If I'm ever paging someone, I'm gonna say, hi, like Harry from team X, this is my phone number and this is the question I have about patient X or Y or Z, and you give their details. You need to be very specific and have a way for the person you're sending the page back to you to call you back, because you can't call off the pager itself. So you need to give them a separate number, like either a landline or your mobile phone number, and then they can actually call you back on that. So yeah. All right, let's go through. Patient on ward 1, bed 1, UCR BP 93/50, please review. All right, so decoding this page, there's a patient on ward 1 who has a low blood pressure. They are hypotensive. Now the systolic blood pressure 93 is not actually that low in like the first instance. Like I'm not like jumping out of bed, racing to the bedside right now. Say if a patient's normal blood pressure baseline is about 150, 160, and they drop to 93, then that's a massive drop. I'm going to be way more concerned about them than if this person is a, post-op, day 0, thin, small person whose baseline blood pressure is like 100 or something like that. So it all depends on the patient, but nevertheless, you need to go and review this patient in person, look at them, why their blood pressure is low, have they just had a medication, have they just had a procedure, are they looking sicker than they once were? Are there other observations abnormal? Do they have like a high resp rate, a high heart rate? Does it contribute to a hypovolemic state? As I said before, are they tachycardic? Tachycardia plus hypotension, I'm thinking they deplete intravascularly and they might need some fluid resuscitation, or they might need some like vasopressors if they really, really need. But in the first instance, just do a fluid review, assess the patient, go through A, B, C's, D's, E's, everything like that, and then just go from there. The main thing that I'm worried about here is, how does the blood pressure compare to their baseline? And has there been anything in the context of this blood pressure drop or hypotensive episode that would make me more concerned than usual? Because if a patient's just been like fasting for ages and now they've just they haven't had much oral intake, maybe someone forgot to chart their intravenous fluid maintenance, it makes sense that they might be a little bit, intravascularly deplete and need to have some fluid resuscitation on board. So if that's the case, all you have to really do for this patient, after excluding other causes of their hypotension, is essentially give them some fluid through the drip. But you need to have like a low index of suspicion for blood pressure being low, because you don't want it to go lower. You need to actually fix the cause of the problem. So I think I just went, assess this patient. They're a little bit low. I think they just had a vomit recently. It's likely opioid induced nausea and vomiting, and we just needed to chart them an antiemetic as well. So we gave them some fluid, we charted them an antiemetic, and we just waited to see their response, and their blood pressure actually pumped up over time. So that's how I did with that patient. If I had all 6 of those pages, the blood pressure one would be the first one that I would go and review, because that is an actual abnormality on their OBS. So that takes priority over all the other jobs that they have to do, because all those other patients are presumably stable and not critically unwell, or potentially critically unwell. So it just says call CT on this extension, read patient Jones. Patient had a scan ordered for the daytime, unclear. yeah, so all the page was it just said call CT on extension, 12345, read patient Jones. And I was like, I just called them. I called up the extension straight away. These are really simple pages to deal with. I called up CT straight away. I just asked them hey, you just paged me. What's the question? Because sometimes you just get these pages like, call back this number, or call ENT reg, or call respiratory reg. And you're like, all right, this could be absolutely anything. Maybe I've ordered the wrong outpatient appointment. Maybe I've ordered the wrong scan. Maybe they just have a question about some random patient linked to our unit. Who knows what it could be? It could be absolutely anything. Pick up the phone, call the person requesting your advice or your response, and just sort out the problem. This patient in particular had a CT scan that was ordered during the daytime. It was not protocoled. So in our hospital, we have to protocol scans. All that means is that you order a scan, but then you actually have to call up the radiologist and you say, hey, I want this scan because of A, B, C, D. And they say, okay, that sounds reasonable. Let's try to do it today. Or maybe there's no space, you need to do it later tomorrow or something like that, who knows. Or they'll say, I don't know if this is the best type of scan for this person in this clinical scenario. And then you say, oh, no, I think it is. And then you go back and forth and you have like a little discussion about it. It may or may not lead to them doing the scan, or maybe you do an alternative scan, something like that. Anyways, this patient had a scan ordered. It wasn't really clear in the notes. I did a look through. This is not something that I need to call up someone about right away. This is a page I got later on in my shift, just before my handover. And I was just like, no, this doesn't need to be sorted right now. After hours, there's no urgent need for this scan. This can be a tomorrow problem for the day team to decide. So yeah, after hours, radiologists and essentially most people like to limit discussions to emergency situations. Of course, stuff can still happen after hours, but stuff should happen during the daytime by the treating team. And if it's not sorted, then your cover shift is not to do jobs that aren't done during the daytime. Your job is to look after patients and make sure they're clinically well and stable after hours for the other teams that you're looking after. So it's not a time for you to do discharge summaries for the other team, or for you to prep the lists for the tomorrow's ward round. That ain't your job. So you need to just chill out, think about things properly and say, why am I pushing for this scan now, if at all? And can it wait till tomorrow for the actual treating team to sort it out and reconsider if they need the scan or not? So that's what I did. And the radiologist was like, yeah, fair enough. Sounds pretty reasonable. I wrote a note, handed it over to the team and said, just consider this scan tomorrow or today when I hand it over. All right, so let's go through this one. So patient UR 12345, nil by mouth. The BSL is 4.8, the ketones are 1.6. Look, this patient, you are mainly worried about a thing called starvation ketosis. So if a patient is nil by mouth, their BSLs are in sort of normal range. Their BSLs are in normal range, it's not low, and their ketones are starting to creep up. So essentially what happens is when a patient is not eating, is nil by mouth, you actually go to other sources of your body to break down different parts and, give you energy that you're not getting from anywhere else. Because all we're giving you when you're not eating, when you're nil by mouth, is essentially fluids through the drip. Now, you still need glucose, you still need energy to function. So other parts of the body start breaking down, and one of the byproducts of that is a ketone. Now, if ketones build up as the byproduct of this alternative energy source, they can actually increase the acidity of the blood and actually cause what's called ketoacidosis. What happens is as the acidosis increases, then that can affect different parts of the body. You're worried if they get too unwell from an acidity in their bloodstream that they can start to become symptomatic. Maybe they're nauseous, vomiting, maybe they feel unwell, and then they can potentially keep deteriorating if it's not treated. What you need to identify in this situation is the severity of this. The ketones are not crazy high, but they're still elevated, they're abnormal. So you need to do a VBG. I did a VBG just to check on the pH, essentially how acidic or alkaline the blood is. And this pH was normal, it was like 7.41 or something, I can't remember, but it wasn't acidic, and the other markers were actually fine in that. So they weren't in ketoacidosis, they had ketosis, starvation ketosis, but they weren't in ketoacidosis. So that's the spectrum of what you're looking out for, to be honest. And yeah, essentially what you can do to just avoid this from happening, or to reduce it or decrease it, is add some glucose into the intravenous fluids that you're giving. So whether you're giving someone, 0.9% sodium chloride or a compound sodium lactate, otherwise known as a Hartmann solution, you can essentially just change that and add 5% glucose or 5% dextrose into the mix. And that actually supplements the glucose or energy stores, and you can actually start to decrease this ketosis and potential effect of ketoacidosis if it's not treated. And if they're awaiting a surgery, you could also just do the surgery and not make them fast. But people have to wait for various reasons in hospitals to get the procedures that they want to get, or that they need to get, because of all the other people in the hospital. So yeah, coordinating that, this can be a complication of it. Or for another reason, they might not even be, for an operation, and they might have other things to do. So yeah, that's how I dealt with this page. This page is very, very common in surgical patients. It said, patient passed out, patient now dizzy and short of breath, please review. Now, this was a pretty serious one. I sort of responded pretty quickly to this, as you would. You're worried if this patient has passed out, if they've fallen, if they've injured themselves, if they're still passed out, if they're still unconscious, or have they actually come to. When I got to the patient's bedside, they were actually in bed. They had essentially lost consciousness, had a syncopal episode. They essentially had a syncopal episode when they were sitting in the toilet. And so when they got up to go to the bathroom to mobilize, and they were with a nurse, they sat down, they didn't have a head strike, and they didn't injure any other parts of their body, but they essentially blacked out because when they stood up, they probably had a postural hypotension episode. They were intravascularly depleted upon mobilizing from a lying or sitting position to a standing position. And this can be for a number of different reasons, but if they have a bit of a low blood pressure to begin with, then they stand up and their blood from gravity just goes all the way down to the legs and away from their brain, they can actually black out or lose consciousness. Also, they said in this page that they were dizzy and short of breath. At the time, they were a little bit dizzy before passing out, so that was a prodrome symptom. So that was part of the prodrome before they actually fell or before they actually lost consciousness. And then short of breath, I'm not sure. I asked the patient, I had to listen to the chest, there was nothing that was showing up. So potentially part of the prodrome or postdrome, but nothing to be concerned and no injury to the chest at all. So yeah, this is something you worry about. You worry if the patient is more unwell than they actually are, but you just go, you assess the patient, you look at them, and then you actually make sense of the words that you've been sent. So going through everything, you just being pretty diligent with working a patient up from scratch and trying not to miss anything or cut any corners. I think that's the key takeaway for all these pages is you get some information, but that information is only 3 lines. That doesn't sum up the person and how they are collectively for their entire admission, for how they're going right now, for what's happened. So there's a whole spectrum and there's a whole range of what the person could be like. You need to actually assess most people in person to make sense of that. And especially from someone else's point of view, you can't take that as gospel and essentially rely on that information. As you get more senior, and if you're talking to more senior people, that might be appropriate. You might be able to communicate how a patient is, how sick they are or well they are based on a few different things. But that's senior colleagues talking to each other, especially when it's different levels of colleagues. essentially when you're quite junior and you're talking to different levels of people who are not trained in the same way you are, you can't actually take their information as, that's exactly what happens. Or, I mean, I'm not saying that this is not what happened, but you just need to assess the person in real life and not just give some phone advice and say, oh, give some fluid through the drip, or lie them flat, recheck their blood pressure, see how they are. You need to just go and assess the person. So yeah, I think that's the main takeaway for a lot of these pages, is that sure, you can assume that the patient is well, they don't have anything wrong with them, or it's actually fine and a benign cause, but you don't actually know that, and you can actually get burnt if you ignore signs or don't do your proper job. But yeah, so yeah, that's it. All right, the last one. This is a more urgent one. It's a Met call, patient UR 12345. There was actually no information. What they do is they announce a Met call, which is a medical emergency, over the PA system, and they say Met call, Ward 3 East, Bed 2, treating team, thoracic, or treating team ortho, or whatever it is. So what it is essentially it's not actually like an arrest, but the patient is sick. They might have a severely deranged vital sign, like maybe their heart rate, like for this one, their heart rate was about 140, and they're in a episode of rapid atrial fibrillation. This was an acute on chronic episode of rapid AF for this patient. They had a number of different things going on with them. They were like 2 or 3 days post-op, they had a chest infection, and they were actually not going so well. So having an exacerbation of their already diagnosed atrial fibrillation is not unsurprising in this context. But you need to go through A, B, C's, D's, everything like that. Make sure they're stable otherwise, and you optimize things like their electrolytes. You make sure that their medications are correct, or maybe you add some medications. For this patient, we actually needed to give them some more digoxin, which is actually a rhythm agent for atrial fibrillation. We added some metoprolol because they don't think they were on regular metoprolol. And yeah, we just sorted it out like that. So essentially what we did for this is, so for Met calls, what happens is that you're one of the junior doctors on the treating team. You go to the Met call. There's also a ICU nurse liaison. So they're the nurse from ICU who comes across as well, make sure that the patient is okay. There is also a medical registrar who comes as well. And of course the nursing staff, the nurse in charge, and also the bedside nurse, and any other people from the ward who need to help or have been asked to help for whatever reason. There might be additional people as well, like depending on how the hospital is structured, everything like that, and the availability of different people. But for surgical Met calls, surgical registrars are most often in theatre or somewhere else, and it's mainly the junior doctors, so the resident and the intern, who attend these Met calls. Obviously, if the surgical registrar is around on the ward, then they would come, or if they're in clinic and they really need some advice about what to do for this patient, then they would come. But from my experience, the surgical registrars very rarely come to these Met calls. They're often busy with other things, but the medical registrars, very diligent, Not that the surgical registrars are not diligent, but they are actually in different locations doing other things. So yeah, that's how I would deal with the Met call. Met calls are alright, like you get better at them over time. You often, as a junior doctor, you just essentially grab a computer, start writing, or grab some paper and start writing. You want to document everything because you are very much overwhelmed and not sure what to do. And that's not a bad thing at all. Essentially, your job as a junior doctor in a Met call is to provide the more senior people with information. You know the patient the best because you've been on the ward. So if that's all you can do, that is the best thing that you can do in a Met call, or a code blue for that instance. So in a code blue, there's more senior people. There's more people, and there's potentially more senior people, like an anesthetist, an ICU registrar, and more like senior doctors who come. And yeah, you can essentially go through that patient with them, give them all the information that they need. Maybe you can assist with, if they're actually arrested, you can assist with chest compressions, or maybe you need to pop in a drip, get some bloods, or give some medication. You can do that through your procedural skills. But yeah, most of your job would be providing information. And as you get more senior, you can actually take on a more diagnostic role and treatment-based role, where you're actually the one deciding what to do, calling the people and implementing the management steps for solving that patient's cause for that met call. So yeah, 10 pages, done. Let's go through the next 10 in another episode, okay? Because that was a long-winded discussion. But yeah, hopefully that helps. That's the first 10 pages.